Hello everyone, I'm Ravi, one of the associate consultant working in neurology department under National Neuroscience Institute, and I'll be presenting this topic with my colleague Ms. Shannon Ang, a senior clinical pharmacist. Both of us are currently working in Singapore General Hospital. Today's topic is pharmacological management of stroke, antiplatelet use in acute and secondary stroke prevention. Our objective for this talk is describe antiplatelet drugs used in secondary stroke prevention and understand the difference and rationale for choice of antiplatelet drugs. Stroke management can be divided into hyperacute and acute management. Hyperacute management is within 4 to 6 hours of symptom onset, and the treatment offered can be intravascular thrombolysis or mechanical thrombectomy. Acute management starts after 6 hours to 48 hours, where antiplatelet statin therapy or anticoagulation is initiated. Based on the stroke etiology and contraindication to blood thinners like severe anemia or hemorrhagic conversion of infarct, etc. This topic has following contents: antiplatelet drugs in stroke, aspirin, clopidogrel, combination of aspirin and dipyridamole, and ticlopidine, role of dual antiplatelet therapy, and resistance or non-responsiveness of antiplatelet agents. In general, blood thinners medications are divided into antiplatelet drugs and anticoagulation drugs. Antiplatelet prevents clot formation via prevention of platelet aggregation. It's used for patients with non-cardioembolic stroke with etiology like small vessel disease and transient ischemic attack. Anticoagulation drugs targets the blood clotting factors to prevent formation of clots. It is used for cardioembolic stroke or TIA, for example, conditions like atrial fibrillation or intracardiac thrombus. In this presentation, I will only discuss about antiplatelet drugs. Antiplatelet drugs commonly used for secondary prevention of vascular events in Singapore are aspirin, clopidogrel, combination of aspirin and dipyridamole, and ticlopidine. On average, these agents reduce the relative risk of stroke, myocardial infarction, or a vascular death by about 22%. My first agent for discussion is aspirin. Its mechanism of action is it irreversibly inhibits formation of prostaglandin derivative, that is thromboxane A2, via acetylation of platelet cyclooxygenase, thus inhibiting the platelet aggregation. Dosing of aspirin. Loading dose is 300 mg, which is to be administered within 24 to 48 hours after stroke onset. The daily maintenance dose is 100 mg. For those patients who are treated with IV alteplase or intravascular thrombolysis, aspirin initiation is generally delayed until 24 hours. Advantage of aspirin. This antiplatelet agent is the most widely studied among all the antiplatelet agents. It has shown to reduce the rate and severity of early recurrent ischemic stroke when started within 48 hours of stroke symptom onset. Disadvantage of aspirin. Aspirin is not suitable for patients with asthma or known allergy to NSAIDs. Aspirin has risk of bleeding, especially gastrointestinal hemorrhage. Annual risk of serious gastrointestinal hemorrhage is 0.4%, which is 2.5 times the risk for non-users. Risk factors include older age, peptic ulcer disease, Helicobacter pylori infection, concurrent chronic use of medications that may increase the bleeding risk like steroids or anticoagulation. The second antiplatelet agent I'm going to talk about is clopidogrel. Its mechanism of action is it blocks P2Y12 component of ADP receptors on the platelet surface, which prevents activation of GP2B3A receptor complex, thereby reducing the platelet aggregation. Its dosing, the loading dose is 300 mg during the stroke onset, and the daily maintenance dose is 75 mg. Let's talk about advantages of clopidogrel. It can be used in patients with allergy to NSAIDs, like aspirin allergy. As per Capri trial, in selected patients, clopidogrel is slightly more effective in decreasing the combined risk of vascular event or death in patients with symptomatic atherosclerotic vascular disease. However, clopidogrel did not demonstrate superiority in preventing recurrent stroke among patients with a history of stroke. The rate of serious hemorrhages were higher in aspirin group. As per another trial called PROFESS trial, which studied the efficacy and safety of two regimes, clopidogrel versus aspirin and dipyridamole combination. The results were There were similar rates of recurrent ischemic stroke in both the groups, but lower risk of hemorrhagic events in clopidogrel group. Disadvantage of clopidogrel. The most common side effect of clopidogrel is rashes, which includes few cases of thrombotic thrombocytopenic purpura also. Initiation with daily dose of 75 mg does not produce maximal inhibition of platelet aggregation until 5 days. Effectiveness may be affected by variability with CYP2C19 genotyping or drug interaction, as clopidogrel is a prodrug. Now, my colleague Ms. Shannon will talk about the other antiplatelet agents.
The third antiplatelet option is the combination of aspirin and dipyridamole. Dipyridamole inhibits phosphodiesterase and augments prostacyclin-related platelet aggregation inhibition. The usual dose used overseas is a combination tablet of aspirin 25 mg and extended-release dipyridamole 200 mg twice daily. As this dosage form is not available in Singapore, the dose that we commonly use locally is aspirin 100 mg once daily and immediate-release dipyridamole 150 mg 3 times a day. As demonstrated in the Aspirin trial, this antiplatelet combination is at least as effective as aspirin alone for secondary stroke prevention. The composite outcome of death from all vascular causes, non-fatal stroke, non-fatal MI, or major bleeding complications occurred in 13% in the combination group versus 16% in the aspirin group. A major disadvantage of using dipyridamole is that it commonly causes severe headache, especially during therapy initiation. Due to the non-availability of the extended-release dipyridamole tablets in Singapore, we commonly use immediate-release dipyridamole 3 times a day. Patients may find it difficult to adhere to the 3 times daily dosing. Moreover, it is debatable if the modified dosage regimen that we use locally will result in the same benefit for our patients, as the trials conducted mainly use the extended-release dipyridamole formulation. The last antiplatelet that we will be discussing is Ticlopidine. Ticlopidine, being a platelet ADP receptor antagonist, has similar mechanism of action as clopidogrel. The usual dose is 250 mg twice daily, and this drug can be used as an alternative for patients who are allergic to aspirin. However, ticlopidine has risk of causing serious adverse effects such as neutropenia, thrombocytopenia, and aplastic anemia. Therefore, its role in current clinical practice is limited and has been largely replaced by clopidogrel. One common question regarding use of antiplatelet in stroke is if there is any role of using dual antiplatelet therapy of aspirin and clopidogrel. I will be referring to this combination as DAPT for subsequent discussion. As shown in the MATCH trial, long-term use of DAPT is no more effective than clopidogrel alone for secondary stroke prevention, and it may lead to high risk of major hemorrhage, including intracranial and gastrointestinal hemorrhage. 2.6% life-threatening bleeding have occurred in the DAPT group versus 1.3% in the clopidogrel monotherapy group. This difference in bleeding events, however, did not result in any difference in mortality between the treatment groups. Therefore, major guidelines such as the American Stroke Association do not recommend the use of long-term DAPT for routine secondary prevention after an ischemic stroke or TIA. However, there are some patient groups who may benefit from short-term DAPT use. The first group of patients are those with acute minor stroke, defined as NIHSS score of 3 or less, or high-risk TIA with ABCD score of 4 or more. This was supported by the CHANCE trial, where 21 days of DAPT, begun within 24 hours of stroke onset, was shown to be superior to aspirin alone for reducing the risk of stroke in the first 90 days, and does not increase the risk of hemorrhage. New stroke occurred among 8.2% in the DAPT group versus 11% in the aspirin monotherapy group. The second group of patients who may benefit are those with recent stroke or TIA within 30 days attributable to severe stenosis of a major intracranial artery. This was suggested by comparing SAMPRIS trial medical patients and the WASIT trial patients meeting the SAMPRIS eligibility criteria. The patients in the SAMPRIS trial were given 90 days of DAPT, while those from WASIT trial received aspirin or warfarin monotherapy. Rates of stroke and death within 30 days after enrollment or after a revascularization procedure was much higher among those on aspirin or warfarin monotherapy compared to those who were on DAPT, with adjusted hazard ratio of 1.9. Based on this, the American Stroke Association guidelines suggest that it may be reasonable to consider giving 90 days of DAPT for selected subgroup of patients. Another commonly encountered question is what is the best treatment option for patients who are adherent to their antiplatelet therapy and yet present with a new non-cardioembolic acute ischemic stroke. Many studies have shown that a substantial minority of patients taking aspirin or clopidogrel are resistant to the effect of these drugs as measured by platelet function testing. The cause of this differential patient response to antiplatelet drug assays is multifactorial and may be related to comorbid conditions such as diabetes, genetic factors, and concomitant drug use. Theoretically, switching to alternative antiplatelet agent appears reasonable as the new stroke could be an indication of poor response to the previous antiplatelet. However, thus far, there is no clear evidence from literature to support switching or adding alternative antiplatelet agent for additional benefit. Clinicians will have to decide on the most appropriate choice of agent based on individual patient characteristics. In summary, in most patients who present with acute ischemic stroke, antiplatelets are often considered after appropriate hyperacute management, such as intravenous thrombolysis or mechanical thrombectomy. In most cases, aspirin within 24 to 48 hours of stroke onset should be started while determining ischemic stroke mechanism, following which, in patients whom are determined to have non-cardioembolic stroke, lifelong antiplatelet therapy is recommended unless contraindicated. Commonly used antiplatelets include aspirin, clopidogrel, and combination of dipyridamole and aspirin. Selection of antiplatelet agent should be individualized on the basis of patient risk factor profile, cost, tolerance, relatively known efficacy of the agent, and other clinical characteristics. In selected group of patients mentioned in the earlier slides, short-term use of aspirin and clopidogrel may also be recommended. These are the references that were used for preparation of this presentation. Thank you for your kind attention.